So, welcome to our very first expert panel discussion on the treatment of arthrofibrosis. We have with us three expert physiotherapists. We have Jamie Palmer from the US, Othmar Hauer from Austria, and Sebastiano Nutarelli from Switzerland. So, arthrofibrosis is characterized by excessive scar tissue formation, joint stiffness, and pain. It often arises as a complication following surgery or trauma, and it can be a truly debilitating condition. Arthrofibrosis might not be the most popular specialization for physiotherapists. So, Sebastiano, how did you recognize that specialized treatment for arthrofibrosis patients was lacking? How did it catch your interest? Oh, you're muted.
Nice. Thank you very much. So first of all, welcome everybody. Thank you for having me. Well, it caught me, I would say, as a patient myself. So the whole thing happened because I was one of the lucky ones that got the pathology itself. So what I would say is I was a professional athlete, or anyway, living my life, and then as a consequence of a minor injury, or then I had to have a minor knee procedure. I developed knee stiffness, and basically what happened was that I went through the classic story that every patient lives, which is undiagnosed origin of stiffness of the knee, some level of pain, but I would say pain was not the main thing. And for a year and a half, in my case, I traveled around my country at the beginning and then the world to try to understand what is it what I had. And so in the end, to get a label on it and have a name, hence a diagnosis, it took me a year and a half. So it is not out of a special interest of mine. I didn't discover this on books or online. I just happened to be one of the patients, one of the lucky ones. And then the whole thing sort of turned in being a clinician now, treating these patients. So the special interest is trying to do hopefully a little bit better than what I received as a treatment, and offer different options and hopefully earlier diagnosis and treatment to these patients.
And how about you, Othmar?
Yeah. My first contact with surgery mother had. This time I was young ski instructor, and that I wasn't neither a sports scientist and not a physiotherapist. I was just a ski instructor, and I was very interested in the way which my mother went and how it became good, and was very well in my memory. And years later, as I was a scientist and physiotherapist, I happened that the first patient came to me with arthrosis. I remembered a lot from therapy mother had. I had a lot of thoughts. I had a lot of physiotherapy. Very clear that's not the correct way to treat it. Then I remember that arthrosis is close contact with CRPS, and there are certain patterns in personality who tends to get arthrofibrosis and CRPS. And in my experience, my mother got both arthrofibrosis in the knee and CRPS on the hand. And so things came running, and I wanted to know more. I want to go my own way, and some good, sometimes good success. Reason why I'm here, but me myself as an expert, whatever, expert.
And Jamie, how about you?
Yeah, I specialize in working with athletes after ACL or multi-ligament reconstruction, and from the nature of that population, um, over time with practice, ended up having a few patients of my own, as well as patients that were referred in that ended up with a diagnosis of arthrofibrosis, and that's how I became aware of this group as well. And so I think seeing especially the patients that had been through 2 or 3 other surgeries or had seen 2 or 3 other physicians, similar to what I'm sure you experienced, Sebastiano, um, recognize that this needs a little bit more special focus and can hopefully improve the standard of care offered from all other providers by paying attention and then kind of spreading out the education. So just from having multiple patients come through the care center that I worked at that have this condition and seeing how it affects their life, but then also what are the things that we were able to do to help them or to do better for them.
Thank you all for sharing your stories and the background, how you got to arthrofibrosis. So it's early recognition and adaptation of treatment plans are crucial to prevent worsening symptoms and give the best chance of recovery. Sebastiano, how do you ensure that you're detecting the earliest signs of arthrofibrosis in your patients? And what specific changes do you make to the treatment plan?
Well, I would say, to keep it simple, as soon as the overall rehabilitation in acute phase, let's say post-op, doesn't go the way it should, most probably something's happening. So I would say usually we all expect as physios an evolution of pain, range of motion, recovery, overall inflammation, to progress in a certain way. So regardless, obviously this is dependent by the level of injury and the invasiveness of the surgical procedure. And again, I'm just assuming we are post-op, but things should anyway evolve in a certain way. This always happens. If it doesn't, in the first weeks, even in the first days, we sort of have these rules now, rule now in our clinic, and we are 15 clinicians, 15 physios treating patients with potentially with arthrofibrosis. That if in the first 7 to 15 days it's not evolving as it should, it's probably it is an onset of arthrofibrosis. So when you're lacking extension beyond 7-10 days, usually also beyond 3-4 days, if it's not major surgery, it's not a good sign. If things are overreacting, we sort of try to have a special care for this patient. Let's say that patient X, and for patient X, we have an eye on him or her. We try to see him every day or any way to, again, track the evolution in a more tailored way. If things are definitely not evolving as they should in 10-15 days, it is arthrofibrosis, especially if it is lacking range of motion, especially extension. Flexion, we always want our knees to recover, flexion as well, but flexion is way easier to recover, and it's not an indicator for arthrofibrosis. I mean, you can struggle with flexion, still not having arthrofibrosis. But if you're lacking extension and you don't, we have plenty of publications, and we know this. If you don't recover extension in 7-10 days, this is a major predictor for you not recovering extension down the road, 1 year, 1 month, 3 months, and then 1 year down the road. So whenever this happens, what we change is, okay, let's say this is an arthrofibrosis. Maybe we are overreacting. We don't scare the patient. We say, hey, listen, this is just going slowly. It's just going in a direction we don't like. So now we see you every day. You want to make sure you don't fall into that. So what we do is we completely focus the joint. We don't care about the muscles. We don't care about the classic evolution. You don't have to leave crutches earlier on. You're not racing anymore. The point is, let's make sure your knee settles down. Let's target homeostasis. And when again, swelling resolves when, I'm not going to make it simple now, but when things come back to be, let's say, normal, back on track, with a triple dose of being cautious, then we evolve again into a sort of a normal rehabilitation. But the goal for us, again, is early recognition or early suspect that this is possibly happening. If you miss this, then it's a disaster. If you don't miss this, so the opposite, it's actually easy. So I don't want to sound like we have full control of this, but really, if in the first 15 days we might diagnose what's happening in 90% of the patients, we might save 90% of them, rather than falling into being in a situation in which it's too late, and then it's established, and then it's a very major complication.
So I understand that early recognition is very important. So given the complex and prolonged nature of arthrofibrosis recovery, clear communication is essential for setting realistic expectations. So Othmar, how do you effectively communicate the chronic nature of arthrofibrosis to patients, and what strategies do you use to keep them motivated throughout the lengthy recovery process?
Very easy to explain. I try to explain this my side of this. It's a stress pathology, which means stress can have many phases, sometimes different phases combined. This means mechanical stress in the joint. This means stress in expectations of therapists, personal expectations, whatever, the expectations in performance and so on, and psychological stress in family, partnership, whatever. And in my experience, I'd say 100% of my patients with arthrofibrosis have a combination of this stress. The easiest to bring on a good way are those with a major stress in mechanics, joint mechanics, and the hardest are those with a stress in psychology, which means family, deaths in family, whatever. And one goal which I try to reach is that the patients understand the way of stress, and they learn to reduce stress, which whatever the major part is. And that if this understanding is here, we get further on. Mechanical stress normally only can be solved with following surgery. If this surgery is well made, which means the surgery itself raises the tissue stress not furthermore, then we come on a good way. And all the other parts of stress in the patient's lives, especially forced therapy and so on, have to be reduced, adapted, and then it gets more or less neurological therapy and not an orthopedic therapy. And if the tissue loses the stress, it is able to adapt again in the way we want the adaptation. That's my goal. And yeah, I have to explain very often and more that patients can take it. It's not easy to take. Normally, my patients with arthrofibrosis, those are performance people. They want to perform, they want to be strong, and so it's a very for most of them, it's a very new experience to get on with reduction of effort.
I see Sebastiano wants to respond. Sorry to interrupt, to hear what Sebastiano has to say.
Yeah, if I may, I mean, the only thing I wanted to add is because I mean I went through this, so I had I was lucky enough to experience this, and again, we all know experiencing a pathology is very subjective. So your experience is not going to be the experience of the other patients, which is also a thing we need to consider. So it doesn't matter if you had pathology A, all the patients you would treat with pathology A will be living and experiencing the pathology in a different way. But just a comment on the stress factor on top of what Othmar was saying, the pathology itself is the biggest stress factor these patients are going through. Some of them, I would say, let's say flat 100% of them, they happen to have this for whatever reason that I'm not digging into for the moment. And this is a major stress factor. As soon as they realize how impacting this is, and usually these patients are the first to realize this, these clinicians are the latest ones. As clinicians, we most of the time we fail to understand how serious this is. But these patients are incredibly stressed because they feel how serious this is. And so I just want to say that a lot of these patients, when finally they get here or whatever else, and they get a diagnosis, the major relief you can see on their faces, just because of all of a sudden, oh, then it wasn't on my mind. It's a real thing. And I wasn't stressed on inventing the whole thing, which is not what Othmar was saying, clearly. I'm just saying the psychological side and burden of this pathology is potentially devastating. So even the strongest person, and again, this pathology can happen to different personalities, even the strongest person can really fail to cope. So we need family, we need support, we need to be very understandable, and very I would say, and empathic in understanding how stressful itself this is. Then clearly there are traits that can, as Othmar was saying, this is possible, but I just want to point out that the pathology itself, being unlucky, because in the end it is not a gift. Something happened to you, and it could have been an easy meniscal tear repair with a 2-3 months, 4 months, whatever, recovery with no issues down the road and recovery. But these patients just happen to be very unlucky, and this is as soon as they understand that, I mean, this is very complicated to deal with and causes stress.
Yeah, it certainly does. So back to the physical parts of the treatment. What we often see is that patients with loss of range of motion get forcing the range of motion. And forcing range of motion, also referred to as overpressure, can cause additional tissue damage, inflammation, and scar tissue formation, actually worsening the condition. So Jamie, a question for you. What alternative techniques do you use to improve joint mobility without causing further harm?
Yeah, I think it all starts with how we educate the patient on what sort of pain levels that we don't want to see when it comes to the range of motion. Because we can feel the joint stiffness as we push them through, but they can feel what the pain response is. And so educating the patient that pushing through pain with their range of motion exercises will not speed up their recovery and may oftentimes slow it down. So there's some pain scales in the literature where they talk about kind of how to improve it or how to progress or regress. I like to use the Delaware pain and soreness rules, where we don't want the pain or soreness that they're feeling to, with the range of motion exercises, to rise higher than a 2 out of 10 increase on a pain or soreness scale. And then in addition, any delayed onset soreness that they shouldn't be having lasting more than 24 hours. So I always like to start with that, and we often have to repeat it. We have to repeat it to the patient just so that we can continue to follow those rules so that we're not getting that overpressure into pain that could be causing those inflammation or irritation. As far as physical techniques that I use or that I encourage people to use, can include joint mobilizations to not exceed end range. So staying in a pain-free, again, range of motion, not trying to get to that overpressure or beyond natural range of motion, as well as really encouraging frequent sessions of range of motion throughout the day to help with synovial fluid turnover and joint nutrition to just help the cycling of nutrients through the joint. I think that pain-free frequent range of motion or movement is needed to, as much as we can prevent it, to prevent the need from continuing to stiffen. And then, if those are not working, then we can go into recommending mechanical devices such as like a CPM or an extended low load, long duration machine to help stretch at that, again, pain-free range of motion, but hold it there for longer.
Excellent. Thank you so much. So research indicates that inflammation. Oh, sorry. Yeah.
No, sorry. Do you mind if
No
I
worries.
add something on top of
Of course.
what
Yeah.
Jamie said?
Go ahead.
With arthrofibrosis, as he correctly was saying, LLPS, so long prolonged stretch, we're struggling with evidence. So we're struggling with intervention that are proven and supported by the literature to work. Well, actually, LLPS, it does. It's backed up by the evidence. So we do have research on this. Not dozens of studies, but if you dig the literature, there is a solid evidence demonstrating that you can, and this is back to physiology in the end, we can deform tissues, providing what we say a little stress, but often. So what we don't want is elastic deformation of the tissues. It just comes back to where it used to be, so it doesn't really plays a big role. We want plastic deformation. You can obtain let's say the posterior capsule deformation, or anyway, even scar tissue deformations. You can get to the point in which with LLPS, so again, low load, but for a long time, could be 20 minutes every time or whatever it is, you can actually obtain also effective compensation of the pathology. So you can have a patient with scar tissues recovering function, even if the knee is not exactly, anatomically speaking, normal. These knees will never come back to be normal, ever. It doesn't matter. The only point is function. So its functionality is back because we are able to provide an evidence-based intervention, which is LLPS, in terms of flexion or extension, with no devices, with devices. I mean, it's the principle itself. This is actually one of the few evidence-based intervention we do have. And I think Jamie raised a good point in this, because again, when we sit and chat, what is it we do with knee arthrofibrosis? It's just, oh, this is what I do, this is what he does, what she does. And we go by experience or expertise, but this is something we should all do because it's backed up by evidence.
Thanks for your contribution as well, Sebastiano. So research indicates that inflammation actually plays a key role in the pathology of arthrofibrosis, and controlling it is essential before attempting to build muscle strength. So this question is again for you, Sebastiano. How do you prioritize and manage inflammation in your treatment plans? And what criteria do you use to decide when it's appropriate to begin strengthening exercises?
I think this is probably more an art rather than a science. Not sure there is a rule, but the point is, we're dealing with inflammation, excessive reaction. So the healing process, it is happening, let's say, faster, much more than it should, for whatever reason. We might speculate, but that's what we're dealing with for the moment. I would stick with this principle. So what we need to do is trying to control inflammation in whatever way we can, which means as physical therapists, we cannot just rely on physical therapy itself. We need to have medical doctor on board, because pharmacology, so medications are fundamental in this process. It is true, when I have these patients under anti-inflammatories, so non-steroidal anti-inflammatories forever, yet they are dealing with an excessive reaction. So healing is happening 100 times more, and inflammation is part of it. Again, these knees are warm, are always reacting. Whatever they do, even a small task, they're reacting like they hike the mountain. We need to calm down the whole thing. So we need to have a team involved, and otherwise we might fail even with our best intentions. So again, medications, and I might go with names, but I don't think it's the right approach for the moment. We have you can use different approaches. Again, very few actually. At the moment, only one anti-inflammatory is proven to limit fibrosis formation within the joints, but just one study supporting that. So we know it can help, which is celecoxib, but also, or Celebex, whatever it is, the name in your country. But again, it's not functioning and working well for all the patients. Then let's come back to physiology again. If things are happening 100 times faster, what we need to do is slow the process, which is basically the target of cryotherapy and compression. We don't use cryotherapy because we want to have the knee cool down. We want to have the metabolism slowing down. So the goal is just make sure things come back to a normal pace, or anyway, slow down what's happening way too fast. So again, we have these patients usually renting, or we encourage this patient to buy a cryotherapy device, which is providing cryotherapy from the hip to the ankle, just making sure with a long wrap that they can get cryotherapy and compression, because it helps. And again, there are studies supporting this. It is true these studies might be biased, because sometimes these studies are supported by the producer of the device. But yet with thermocameras, there are some studies actually proving that it gets a deeper effect. And then it's load management, I would say, which is our job. We can have a doctor involved, but a physician involved. But in the end, if you just go the way the protocol is saying, these patients will deal with tons of inflammation. We need to have a special care for them. So they stay on crutches. It doesn't matter if the protocol says that's an ACL, you should be off crutches in 2-4 weeks. It doesn't matter. You can be, to me, on crutches for 6 weeks, 8 weeks. I don't care. I do care, obviously. But the goal for me is the joint. If the joint is not happy, if we're not dealing with a knee that is finally finding his homeostasis, we will never get anywhere.
Yeah.
So